Autism Canada depends on the generous support of viewers like you. If you find this presentation helpful, consider donating at autismcanada.org.
She's a wealth of knowledge. She's been in this for 30 years, although she looks like she's 30. And when she was in her undergrad, she worked with Dr. Lovas. She has the biggest centers in the world on this continent and others working with children with autism. She believes in a multidisciplinary approach to treatment. She's seen children get better. She believes in recovery. And I believe that ABA is how we all learn. No matter what program you pick, it's ABA. That's the basis of it. And I know that you're going to get that after this presentation. Please welcome Dr. Granpeesheh.
Good morning. No, I'm great. I will just get off here, find my talk. How are you? I hope you're well. Lori was very kind to give me more time than I'm scheduled for because she knows me. I'm going to talk a little bit too much. First of all, Lori, by the way, I was graduate school, UCLA, too. It's very, very good to be here. I don't really do a lot of conferences anymore due to technology, and everybody does webcam stuff, but my fiance is Canadian, so whenever I get invited to Canada, I always accept. And I'm so happy to see the amazing things that Autism Canada is providing you on the information that Lori just presented. That's incredible. I'm going to get on that site myself. I really want to see some of that stuff. And I have to tell you, being from the United States, we don't have a very good system like this where you can just go in and download a physician's handbook and all that sort of stuff. So this is very valuable information you have. I always struggle with my 1.5 hour talks because there are so many important things that I want to present to you here, and I assume that most people here are parents. Can I see a show of hands? How many people here are actually parents? Yeah. Right, so I'm very, very passionate about helping parents, and that is the primary reason I entered this field 34 years ago. So for me, it's hard to cut out slides and say, oh yeah, they don't need to know this. So I spent 2 hours last night trying to shorten this thing, and I just can't. So I apologize if I do end up being short on time. And what I want to say is that at the end, I will give you a lot of resources where you can actually get, this is on the Autism Canada website, but also on my website, centerforautism.com, and I also have a live show every Wednesday, which I answer questions, so I'll give you all that information, and I'll be happy to kind of stay in your lives, hopefully, if you like me after this and want me to. So, usually I start out just talking about what I think autism is. I'm very opinionated about autism, obviously. It's the majority of my life has been in this field. And I feel like everything that's out there is not quite accurate. So what I'm going to do is start out with just giving you kind of a description of what I think autism is. Normally, I would be going into sort of the interplay of the biomedical aspects of autism and the behavioral. But being that you are, I think, the third maybe or fourth conference that I've done after May of this year, all of the diagnostic criteria for autism changed. So I thought it would be probably more important for me to present to you the new diagnostic criteria for autism so that you can kind of understand how the world is seeing autism now, the DSM-5. So I will do that. I'm going to talk about how the DSM-4 used to how we used to diagnose up to May of this year, and how now we are supposed to diagnose, so that you'll have a better understanding of that. Dave, hi. And then I will talk a little bit about sort of the mix of treatments that we like to tell our families to do. And then I will hopefully have at least an hour to talk about ABA, because I understand that there's a lot of different misunderstandings or misinterpretations, or people across the world kind of maybe have different presentations on ABA, and I feel like I'm not arrogant, but I feel like being in this field for 34 years, I kind of know what ABA is. So I will be able to tell you a little bit about that, and then I want to show you how you can access some information that's going to be helpful to you after I'm gone. Okay? So we're going to get straight into it. I apologize because I'm going to go over on time. I'm not going to be able to take questions right off the bat in between, which I like to do, but save your questions, and hopefully we'll have about 20 minutes or so at the end to answer questions. So the autism is diagnosed we have the symptoms of autism listed in a book called the DSM, which stands for Diagnostic and Statistical Manual of Mental Disorders. And up till now, up till May of this year, we have been using the DSM-4, which came out actually originally in 1994. There was a training manual that came out in 97, but essentially the criteria, the symptoms listed did not change since 1994. I say that because the very first question people always ask me is, do you think autism has really increased, or do you think it's because the diagnostic criteria have changed? The diagnostic criteria had not changed since 1994, okay? So the increase over the course of the last 2 decades is very real, has not really anything to do with the diagnostic criteria. Having said that, I started training in this field in 1978, and the diagnostic criteria did change 3 times during the course of 78 to 94. And the reason I tell you that is because for parents here, I want you to understand that this label doesn't really mean anything. It means that we put together a bunch of symptoms that we see in a group of children that we find to be somewhat similar, and we call it a name. So it's important in terms of finding the right treatments, finding the right funding, but other than that, it is not a life sentence. And people often think that if you have a diagnosis of autism, that means it's the end of the world, and it's not. And a lot of children with autism continue to grow and continue to learn and do extremely well throughout life, okay? So let's start with understanding that let's not put too much, effort into understanding what does the diagnosis actually mean, okay? It's really what a bunch of scientists think describes our group of children or group of adults best. Now, up till this year, we would diagnose autism based on these symptoms. Essentially, we'd be looking for 6 deficits total, 2 in the social area, and then at least 1 in communication, and at least 1 in what's called stereotypic repetitive behaviors. So if you had a child who came in and the child didn't have eye contact and wasn't sharing and wasn't able to express emotion or understand emotion very well, and then also had some language deficits or perhaps pretend play deficits or wasn't able to converse with others, and then had any of the stereotypic behaviors, like really insisted on having certain routines, or was preoccupied with small parts of objects, or was really focused on, let's say, leaves or water or sand or so on, and had some motor repetitive behaviors, any one of these. And if the total symptoms of the child were 6 or more, they would receive a diagnosis of autism, actually autistic disorder, okay? And if the child had 2 social deficits, so 2 of those things like eye contact or so on, and 1 of the stereotypic behaviors, but no real basic speech deficits, then the diagnosis would be Asperger's. And if the child had all 3 of the areas, social, communication, and stereotypy, as the same as autism, but fewer than 6 symptoms, then they would have a diagnosis of PDD-NOS. PDD-NOS is pervasive developmental disorders not otherwise specified, okay? So really, it was this kind of three main diagnoses that we were looking at. Does the child have enough severity in the three areas of language and communication, social and stereotypical behaviors, repetitive behaviors, for us to say that the child has autism, autistic disorder? If not, if it's a little bit less, then it's PDD. And if there's no real speech delay, then it's Asperger's. And that's how we used to look at things, okay? Now, the new world of autism, DSM-5. How many of you have actually seen the new diagnostic criteria? So some of you have, okay. It's actually kind of an interesting change. And for someone who's now on, this will be my fourth set of diagnostic criteria, which is also in itself kind of funny, right? If a diagnostic criteria changes 4 times in the course of one clinician's life, what does that tell you? I think it tells me we don't really know what we're talking about, right? We keep changing our mind. So here's the new DSM, and this is, I'm going to go through this with you, and hopefully you'll have some understanding. It's quite different. I like it. A lot of people don't like it, and I'll tell you why at the end, but I like it because I think we're moving finally in the right direction. What we have now is we don't have all three anymore. We have what's called autism spectrum disorders. Okay? Now, autism spectrum disorders, we have to have 4 different criteria met in order to get this diagnosis. The first one is criterion A, and it is the child has to show persistent deficits in social communication and social interaction. Here's where they have joined language as well as social, okay? In criterion A, social and communication have now merged. And you have to have all 3 of these deficits. Makes it a little bit harder for the child to fit, but here they are. You have deficits in the social emotional reciprocity. Remember, we had that already in social deficits. Deficits in nonverbal communicative behaviors, like eye contact, for instance, and deficits in developing and maintaining relationships appropriate to the child's level, okay? So that's kind of similar. We've just joined the 2. Criterion B. Here you have to have the presence of restricted, repetitive patterns of behavior. Remember, this is the stereotypical stuff we had also in the past. But now you have to have 2. Instead of 1, okay? Now they're looking for 2 repetitive types of repetitive behaviors. So these are things like repetitive speech, excessive adherence to routines, highly restricted fixated interests. That's all the same as before. Oh, here's a new one, very, very important. First time ever, which is a fabulous thing they've done, is if your child has hyper or hypo-reactivity to sensory input, this would be considered one of the stereotypical behaviors. Fabulous. That in itself deserves a round of applause. For the very first time ever, we've now actually recognized that kids with autism do have sensory issues, right? So that's a very important thing, right? So, and if you have 2 of these things, so that means if your child has sensory dysregulation, and if there's one of these other types of repetitive behaviors, which, by the way, usually develop if your child has sensory disabilities, then good, you've met the criterion B requirement. Criterion C says that the symptoms must be present in early childhood. Well, guess what? All diagnostic criteria for children have to be present in early childhood. So that wasn't even necessary. That's the case. And criterion D, symptoms together limit and impair everyday functioning. And that shouldn't even be in there either, because that is something that we're all trained on. And I often say this because people will come to me and say, well, yeah, my child does these behaviors and all this, but does that mean he is autistic or has autism? The definition of any disorder is that it must impair everyday functioning. So an example of that is I could go home and drink 3 bottles of scotch, and if I'm very functional and nothing happens and I go to work, I'm nice to my family, I don't have alcoholic disorder, okay? But if I am not functional, then I am diagnosed with a disorder. And the same thing for any other disorder, such as autism. If you have difficulty with language, that doesn't mean you have a disorder. If you have difficulty with social behavior, you could just not really like people. It doesn't mean you have a disorder. Any disorder has to do with, it has to impair everyday functioning. And the way we look at disorders is if you're a child, it impairs your functioning at school. And if you're an adult, it will impair your functioning at work or and in your personal life with your wife or husband and so on. So, do we meet all 4 criteria? Seems very simple, right? It's pretty basic. You have the social and communication delays, you have the stereotypical stuff going on, the symptoms occurred early enough. It is very, very unusual for me to diagnose a child with autism spectrum disorder later than age, let's say, 5. Okay, typically most children, you will have seen the symptoms developing. The youngest child I've seen was 9 months. So you can see symptoms developing very, very early. And sometimes you can see symptoms developing up to age 3, and it can go unrecognized. And people can come back and say, well, it wasn't severe enough and nobody really recognized that he had a speech delay or so on, and now he's 5. But if we have children coming in at 7, where no one really recognized there was a problem before that, then there's something wrong. Okay, there's something else going on if the symptoms develop after 5. Okay, now with the new criteria, if the child meets the criteria for ASD, then he or she will receive a diagnosis with etiology. Now, this is the first time ever, and this is like huge for me. One of the problems that I had, I'm going to go back so you guys don't look at that slide. This is important. So the one thing I hated about the diagnostic criteria up to this point, and you'll completely appreciate this as parents, is that we would list a bunch of symptoms and we'd never say what caused that symptom. Right? Why did my child develop these things? Where did it come from? No one ever asked about the etiology. Like, what was it caused by? Now, this is why it's very, very important. So this is the example I like to use. Let's say all of you in this room have a runny nose and a cough, okay? And half of you, this half, has those symptoms because you have a viral infection. And the other half have the same symptoms because you have a bacterial infection, okay? But it doesn't matter to me because I don't care what caused it. I'm not asking. I just want to know your symptoms. And I'm going to call it whatever. You have a cold, okay? But I don't need to know the symptom, need to know the cause. So they say colds get better with antibiotics. I'm going to give you all an antibiotic. Guess what? The half of you who had a bacterial infection are going to get better, and the other half who had a viral infection are going to get worse. Now, that's why it is important to ask what caused it in each of you. With autism, it's exactly the same thing. These are not just a bunch of symptoms that appear out of nowhere, and as a behaviorist, I can come in and treat them. I have to try to figure out what actually brought the child to this phase. What caused it in this child? Are there underlying causes that need to be handled and treated? That's why the medical interventions become important. Because if you don't pay attention to what's bringing this on for the child, hey, that stimulus could be present. And no matter how much you try to teach the child as a behaviorist, they could still be getting worse. Nobody's really spent any time to stabilize the child or figure out how it came about. And you could give the child wrong treatments, just like the virus example that I gave. So now, for the first time ever, since 1978, and before that it was even worse, we now actually have this thing called specifiers. And the specifier allows us to say what we think is the cause of autism. This is the first time ever. So it'll say, for instance, ASD with Rett syndrome, ASD with Fragile X. I just threw those examples because those are the two examples that most pediatricians will probably use because they're not really familiar with other things, like, for instance, gastrointestinal problems leading to sensory issues leading to autistic symptoms. But it does give clinicians the ability now to say what we feel the etiology is, the cause. And then there are modifiers, which are awesome as well. And the modifiers tell us what accompanies the autism. So, for instance, ASD with seizures, or ASD with intellectual disabilities. That's awesome as well. Like, I can't tell you how proud of the current group I am, the people who came up with this, because up till now, there was a section of the diagnostic manual that said, oh, 80% of kids with autism actually also have mental retardation, which is complete garbage, right? And now they're saying, okay, let's just at least identify the kids who do have intellectual disabilities. Okay, and that's very important. And the reason that people thought that a large percentage of kids have mental retardation is because we use language tests to test IQ. We use verbal tests. How am I going to test your intelligence? I'm going to give you a test that involves a lot of language. You don't speak my language, you don't speak language, you're going to fail. If I took an IQ test in Chinese, I would come up mentally retarded. Okay, it's really that simple. Now, also with the DSM, we have what says early history is specified. This is great, right? So now we're tracking when did this disorder for this child, when did these symptoms actually start, and what was the pattern of onset? Was there a loss of skills? Remember, there was a few years ago this huge sort of dichotomy about whether the child is regressive or not. And now we are actually tracking that. Did the child lose skills, or did the child just plateau? And this actually is kind of an interesting question. And it's important that we do all these modifiers and specifiers, because I'm pretty sure we're looking at easily 3, maybe 5 subsets of autism, maybe more. And we need to start to phenotype autism, because, and when we phenotype autism, we'll actually be able to find treatments that are best for each subgroup, rather than treating everybody the same. Okay, and also now we're looking at ASD, these things like, for instance, because we can say it's, you know, when did it start, we could say ASD with onset before 20 months and loss of words. Or ASD with onset before 32 months and loss of social skills. And you see now we're beginning to see a lot of people said, oh, we don't like the new diagnostic criteria because it just puts everybody in one group. But no, look, it gives a lot more description about the child, about the individual. And this is actually wonderful. Or ASD with no clear onset, no loss. And finally, for those people who say, oh, Asperger's is lost, it's not. ASD Asperger's type. Okay, we can say those things. And also, we can point out, and this is the other cool thing, they thought about a lot of things for this group. If your child currently has a diagnosis, you don't really have to go and re-diagnose, obviously, right? So this is not, I'm not going to go and re-diagnose the child who already has a label of ASD or autism or PDD or so on. It's not necessary. Now, this is the last portion of the diagnostic criteria, and it's also awesome. Here we are. It allows you to give level of severity. And the level of severity has to do with the social communication. It has to do with actually 3 areas. It has to do with how much support the child needs. It requires some support, substantial or very substantial. And it's defined based on the social communication abilities and the restricted repetitive behaviors. And obviously, the more the child can't communicate and the more they need help with repetitive and so on behaviors, then you will get more and more support. And this is hugely important when you do the diagnosis and it says level 1, 2, or 3, because this will have to do with separating children in schools, for instance. This could be a very high-functioning child. This could be a child who needs a lot of support. So this will help us. And also in terms of funding, right? And I am a very positive thinker. I am always an optimist, and I want to believe that the reason we did this was to give each child the help they need, rather than cut out help from as many kids as possible. We'll have to see how the funding sources use this. So, one of the things, okay, I'm going to go back again. My next slide is a good one. So that's the new diagnostic criteria, okay? And now they've added one new diagnosis to the DSM. And this is kind of important because the following diagnosis didn't exist before. And this, I think, is why people are a little bit worried. Because the following diagnosis is similar to our high-functioning PDD children in the past. So the new diagnosis is called social communication disorder. You guys will be the first to really understand this. So the social communication disorder means that your child has problems with pragmatic use of language, so that's kind of abstract language, understanding things like inferences and so on. And also has difficulty in the social use of communication, language communication. So it must affect development of relationships, comprehension, academic achievement, or occupational performance. And the individual the disorder cannot be explained by having mental retardation, for instance, low cognitive ability. And the symptoms must be available in early childhood or present. And ASD must be ruled out, okay? Now what happens is when you have this type of thing come into the book, the fear we all have is that clinicians who are not very familiar with the spectrum will place all of the higher functioning kids into this category and out of the ASD chapter. And why are we afraid of that? After all, didn't she just say that the label doesn't matter? Well, the label matters for funding. And I don't know in Canada, I'm sure it also affects you somewhat in Canada, and I hope soon you'll be going through the same craziness we are. In America, ASD is funded, right? Insurance now provides funding for ABA, for behavioral interventions, in I think 34 states. And if your diagnosis should change to this, you don't get funding anymore. And that is a big issue, obviously. So we're very careful, I'm very careful. For those of you who are parents here, it's really important that you don't, that you really understand the diagnosis, and that if you don't feel your child is being diagnosed right, that for the purposes of funding, that you try to see someone who's more of a specialist in the field. Okay, so we're done with diagnosis. Are we good? Good. So the main differences, I'm going to do this one very quick, and are that, we've now joined some of the things. There's specifiers, levels of severity, and this is the first time we're mentioning sensory issues. It's the first time we're mentioning medical issues. For instance, if the child actually has GI problems, we're mentioning that as a specifier now. But there's still no mention of challenging behaviors, right? So like autism, as I said, you pay attention to the fact that autism is language or communication deficits and social deficits, and the presence of those ritualistic types of behaviors, like insisting things be the same. But no one lists anything about, children with autism tantrum, they hit each other, they're aggressive, they're self-injurious, they run away, they throw things, they bite, they spit, and so on. Why do you think that is? It's not part of the symptom criteria. So why do our kids exhibit challenging behaviors? Any ideas? Possibly they're frustrated. Possibly they can't communicate, so they're frustrated. So they communicate with behavior. If I couldn't make you understand, using my language, that I'm upset, and you came and tried to take something away from me, or tried to move me to the next thing, and I didn't know what's going on, you were just bothering me, you know what I would do? I'd probably push you, hit you, try to bite you, shove you, keep you away from my stuff. That's what I do. So communication is... Our kids show communication through the challenging behaviors. That's what they do, okay? Now, when we look at this, I'm just going to give you one quick slide, which is my view of what autism actually is, okay? So in my mind, we already know that there's a genetic predisposition. There's pretty much a genetic predisposition to a lot of things, because genetic composition changes over time. That's very important to understand. But having that genetic predisposition, certain things in the environment will trigger certain symptoms. So if we are exposed, the genetic predisposition really leads to things like high oxidative stress, decreased methylation, and this means people always, obviously, whenever I travel, first thing is, what do you do? Oh, I treat kids with autism, and then we have 5,000 questions. The first question is always, well, why is it that autism has increased? Okay, and my answer is always, well, I think there are too many toxins in our environment. That's the easy answer, because I don't want to talk about it for 10 hours. So, toxins in our environment, well, that's interesting. We're all exposed to the same toxins. Then how come a lot of kids don't have autism, or I don't have autism, and other kids do? Well, because the genetic component of autism actually leads to what's called high oxidative stress in a lot of children. And that means that they are not detoxing as fast as everyone else. So when you're exposed to a bunch of toxins and you're not detoxifying fast enough, guess what? Some other things may be affected by that, right? Because you have some toxic issues. And those types of things that are affected are often immune functioning. And immune functioning, of course, gastrointestinal inflammation, I'm sure you have heard about that, leads to, a lot of our immune system is actually in the GI tract. And when you have inflammation in the GI tract, we're looking at a lot of other biochemical aspects of the child going wrong. Now we're really not detoxifying fast enough. And a lot of times what you see with our children is these differences in their brain functioning. And sometimes we believe that has to do with just blood flow. There's studies that have been show that blood flow in certain parts of the kids' brains is low. And if blood flow is low to certain parts of the brain, usually the prefrontal cortex, what happens is that area doesn't grow as much neurons and dendrites, or nerve cells, and as a result, what happens is we just start learning differently, right? So in this room, we're all kind of different, our brains. Some of you are very strong with certain skills. That's because certain parts of your brain developed more, and you had a lot of practice in that area. So someone here might be extremely artistic. Are there any musicians in the room? Are there people who are fabulous with concrete numbers? That's brain functioning, right? And because of the fact that each of us have different aspects of our brain stronger than others when we're very little, and that's a genetic thing, and then we practice in that area because, hey, that area is easy for me. I can pick up music very fast. I can't. I'm horrible. I don't play anything. But I'm pretending to be. So if I was a good musician, right, that's only because I was exposed to it early in life and I liked it. And I liked it and I kept doing it. Why? Because it was easy for me. Why? Because my brain functioning having to do with music was strongly developed. That's what happens with our kids. Our kids have sensory issues to begin with due to all the other medical things, biochemical changes. And if you have sensory issues to begin with, you are going to learn differently, okay? If lights bother you a lot, like here, I'm standing here right now, I'm giving this talk, and don't worry, Lori, this is perfectly fine, this light, but it is very intrusive, okay? There's a light on my face, and it's very intrusive. Now, if I was someone who was prone to have migraines from high strong lighting, I wouldn't be standing here. I would most likely do this a lot, and I would most likely just get off the stage as fast as I can, okay? Now, and if I was someone who was disturbed by sound, then I would probably not really want to be around people all the time. I wouldn't really want to hear a lot of noise or sound. If I was someone who heard background noise louder than language, then my focus right now would not be on the speech, it would be on the sound of the air conditioning unit. Do you hear it? The reason you don't hear it normally is because you are trained and because your brain is formed in a way to listen to language rather than background noise. Do you know what my recovered adult kids tell me? They tell me that at certain points in their life, listening to language was the hardest thing because it was like a very faint background noise and there was so much else that was distracting them. What about visual input? Visual input. How many of you here wear glasses? Take them off and imagine that you go through life that way. Okay? You're going to depend on the sensory aspects that you're good at, and you're going to avoid the senses that are problematic or difficult. Think about it. Everybody does, right? On top of that, there's other issues. For instance, if you had gastrointestinal pain, which a lot of our kids do, and I don't want to get into it too much today, but if you did have GI issues, what would happen is, would you even get up the next day to go to work? No, you'd probably self-isolate. You'd probably do a bunch of types of behaviors to calm your pain. There's a lot of biochemical stuff that goes on with our kids that leads to who they are and how they learn. And those behavioral symptoms, delayed language, delayed social skills, and the presence of stereotypical behaviors, we call them autism, but aren't they really just the result of certain sensory things that are going, or certain medical things that are happening? And that's really what it is. So the way I look at it is, okay, once these symptoms have been triggered, how do we treat it? Well, we minimize exposure to toxins, and we do that with all of our kids, right? As much as we can. And by the way, it's a fascinating experience having been in this field for 34 years, because let me tell you, I don't even think it's just minimizing exposure for our kids anymore. I think it's pretty much all of us now. How many people, young women, are having a hard time with fertility? How many people have chronic illnesses? Exposure to toxins is out of control. It's probably better up in Canada than it is in the US, but it's pretty bad right now. So we all kind of need to minimize exposure. And then we treat underlying medical disorders. This is critical because what happens is, I have still parents coming to me saying, I went to see my gastroenterologist. I have a child who has diarrhea 10 times a day. 10 times a day. And they go to see a GI doctor, and the GI doctor says, oh, but he has autism. That's just part of it. What? Like, oh my God, so you're ignoring the fact that the child has serious GI dysfunction because of the label autism. That's actually called overshadowing of a diagnosis, and that's what happens. Autism is a very pervasive disorder. People always say if you have autism, it is severe and lifelong. That is not true. Break it up and treat each aspect of it, okay? Treat the medical disorder. How many of you here, and I don't want to make you feel bad, how many of you here have children who don't sleep? Treat it. Deal with the sleep. It has nothing to do with autism. It leads to more symptoms of autism. How would you function if you didn't sleep? Okay, make sure that you can treat it. Sleep disorder, there was just a recent article on it, that sleep disorder leads to more other types of disorders than anything else. Anything else. So, I'm so happy that the DAN movement, the Defeat Autism Now movement, which I will forever credit to my dear friend, Dr. Bernie Rimland, started people thinking about the medical aspects of autism, right? But there's more still that you should pay attention to. Autism is only language, social, and some stereotypical behaviors, and they're always caused by something else. Try to figure out the other things that are going on with your child. Try to figure out the sleep factor, the dietary issues, the toxicity issues. Those are very important. Identify the sensory. And then, once you've treated the underlying stuff and you identified the sensory, you can teach new learning. That's ABA. And you do this keeping the sensory issues in mind. For instance, if I have a child who's extremely strong visually and has a hard time with auditory input, I'm not going to do just traditional instruction. I'm going to give the child a lot of visual instruction, right? Written words or pictures, because that's what the child's really good at, and that's what standardized testing helps you identify. If I have a child who's a very fast speed, then I'm going to have to work on just reducing the child's speed first, functioning speed, receptive speed, and then able to teach the child a little bit better. So these are important things to be able to identify. If you do all of those things, you are reducing and eliminating symptoms in some cases. And in some cases, you're not going to be able to eliminate all the symptoms. Why? Because we're learning. We get better with time. I can't recover all of my kids. I don't. But I do recover about half of my kids if they start early enough and if they go intensively enough, okay? And that's what our field does. And unfortunately, you know, the field of behavior analysis, ABA, has grown very fast and has gained support pretty fast. And so it's also become an economic type of thing. It's become a business. So a lot of people will get into this field just because it's a business and they can make money. And there isn't any other degree, master's degree, where you can actually make $100,000 a year, right? So be careful when you find your ABA clinician, your BCBA, your board certified behavior analyst. I can say that because I'm one. But I'm a doctor, and I've been in this field for a really long time, and I've seen a lot of people come into this field who have no clue what they're talking about. And they're in the field, and they have a credential, and they try to convince people that they do know what they're talking about. So you have to, I'm sorry, but autism is a weird field. It's a field where the parent is more knowledgeable than anyone else. And you have to be that way. I mean, what other disorder is there where you go to a conference to learn about it? You know, and it's hard, and you still don't even, you could go to another conference right now and they'd be telling you to do something completely different than ABA. So it's important to feel right about it. Nobody really knows your child better than you do. And if you have a good behaviorist, the behaviorist will describe and explain everything to you just like I am today, and probably even slower and better. So what is ABA? It's not too bad. I have about 45 minutes. So we can get into ABA. And this is what started the whole movement of ABA, which was actually what started was a research study that I'll show you in a second. But the Surgeon General in the US said that, hey, ABA is the best way to teach kids with autism. That was back in 1999. And in 87, and I started in this field in 78, and in 87, at UCLA, the guy that I was working with, Lovos, we did this treatment, this research project. And this research was published in 87. It was took us about 5 years to do this. And what we did was we had 3 groups of kids. This is, you guys, back in the 70s, no one even knew what autism is, right? It just was not like now, right? It was 1 in 15,000 children. What is it now? 1 in the 80s. Of course, I think it's even 1 in 50-something now. But we had 3 groups of children. I would tell people I work with autistic children, and they would say, oh, they draw well, they color, they're artistic. This is pre-Rain Man. I mean, imagine how far back this is, right? So, and definitely pre-internet, way pre-internet, 20 years pre-internet. So we had 3 groups of children. This is at UCLA. We had 19 kids who were our group, and then we had 20 kids who were one control group and another 20 kids in control group 2. With our kids, we gave them 40 hours a week of actual therapy, intervention. In those days, it was called behavior modification, same thing as ABA. And in control group 1, the children received 10 hours a week of our therapy. And the reason for that was just we had a shortage of staff, the kids were at a distance, and we had no funding. So it was just a random distribution of some kids got this and some kids got that. And in control group 2, this was another program at UCLA, the Neuropsychiatric Institute, where it was kind of more of a classroom setting. But they also did some behavioral interventions, but it wasn't one-to-one structured the way we were doing behavior modification. For 3 years, right? And we followed all these kids with testing. And this is so far back that you could do this sort of thing because no one knew what autism even is back then, right? Now, out of our group, 47%, that means 9 of the 19 kids, actually recovered. Okay, and they went on, we did a follow-up study that showed they had maintained all their gains in school. We tested them again at 11, at 13, at 17. They had normal, healthy lives. They went through regular education and so on. With control group 1, with the 2 other control groups that received 10 hours a week, both of them, 2% of these kids, that means 1 child actually made it, okay, and went into regular education. That led to the whole field changing. That led to people saying, what? Kids with autism can actually have normal lives? And this is something that's reversible? That's weird. So we went ahead, now this is me and my group, we went ahead and we looked at our kids again back in, I don't remember what year this was, I should probably put the year on this, 2007 or so, and we said we're going to look at all of our current kids or the kids in the past 10 years and see how many of them we have where we have really good data. And we found the first 39 and we published this study. And it showed that all of their measures, like we were trying to prove to the world that, by the way, when we say recovery, we're not joking around, or it's not our personal opinion that this child is recovered. We actually have tested them on everything. We tested them on language, on intelligence, on adaptive functioning, on vocation, everything you can imagine. And these kids are actually doing really well. And you know what? It's since 1986 or 7, I have said some children with autism recover and all others improve. Okay, that's just what my world is, what I've seen. And I still have people skeptical, and I bet there's people in this room who think I'm crazy. But the truth is, I now have a lot of adult friends who were my kids when they were 4 and 5. And they're also work at CARD. One of my PR people is someone I treated when they were 4 to 7. One of our people in social media is our statistician with whom I've published. Was he on this study? No. Our statistician has his master's from Cal Poly, in statistics. He works for me. There's a lot of kids who now are adults and are doing extremely well and have gone through college and have done very, very well. And you know what? Yeah, some of them, they use their skills, and some of them are not the most, social people in the universe, but guess what? They're fabulous in a lot of other ways. Like one of my kids just got his Ph.D. at Georgia Tech in robotics and is now going to help us build robots to help kids. Like, I'm sorry, what is not normal about that? That's awesome. So, and these are the kids, and that's the stuff that they are capable of doing. And, I'm going to forever be brave enough to say, yes, some of my kids do actually recover. Let's go into what is applied behavior analysis. Okay, are we doing okay? I apologize, I know I'm speaking very fast. It's 9:36. I know, but I have about 60 slides. Okay. So ABA is, I'm going to give a very brief definition first of ABA. It is based on the principles of operant conditioning theory, okay? And operant conditioning theory is this. All human behavior is affected by events that precede it, which are called antecedents, and events that follow it, which are called consequences, okay? And if we can change these events, the antecedents and the consequences, then we can change behavior. That's it. So, an example. Right now, I was just told what time it is. That would be the antecedent. The behavior is my speaking speed. Will probably speed up a little bit in order to be able to finish this presentation. So that's an antecedent modification. If I was just told that I have an hour and a half, I'd slow down. So the antecedent affects my behavior, right? How does the consequence affect my behavior? Right after I say anything, why am I looking around at you guys? Yes, I'm polite and want to look at you, but I want to see your feedback. I'm looking for your feedback. That's my consequence. If my feedback is you're falling asleep, guess what? I'm going to move on to the next slide. If my feedback is, oh yeah, she's a brilliant speaker, then I'm just going to keep going the way I am, right? So your feedback, your consequence, changes my behavior. So antecedents and consequences change behavior. So let's look at what do we want to change in our kids? What kind of behaviors do we want to change? This is how a behaviorist will evaluate your child. Oh, there are certain things that are deficits, like language, play, social skills, theory of mind, which I'll explain shortly. How many people here know what theory of mind is? Canadians are so smart. You're the best people. I say this because I'm marrying one, I have to say that. So executive functions, these are all things that are deficient. And what are some things that are excessive? Self-stimulatory, those repetitive behaviors, there's too many of them. We all have self-stimulatory behaviors, right? Like I might hold this and like do this with it. That's self-stimulatory, it's repetitive, it's meaningless. How many people do these types of things? Or I'm looking to see how many people might be, you're moving your foot, that's kind of a little bit self-stimulatory in nature, right? You're playing with your hair, that's all self-stimulatory type stuff. But it's just normal, we all do it. It's not excessive. But in our kids, it is excessive. It takes away from them paying attention to anything else. That's why it's not good. And our kids have these excessive things like, I'm sorry now, I made both of you very conscious of your behaviors. I apologize about that. So now, our other things with our kids are maladaptive behaviors, which we said are not part of the actual diagnostic criteria, but they're a pretty common side effect, right? So a lot of our kids tantrum. They have aggression, they have non-compliance, they don't know when to listen or do the things that we ask them to do. And our goal in behavior intervention is to increase the skills in this area and decrease the behaviors in those areas, right? That's our goal. If we want to make our kids fit in, we really want to just increase their skills and decrease their challenging behaviors. That's really it. Now, this is called skill repertoire instruction, skill teaching, and this is called behavior management, okay? And in very basic terms, a behaviorist will reward these types of things and remove rewards when these types of things happen. Very, very simple. I'm going to talk a little bit about each of those areas because they're both critical. If your behaviorist is doing one or the other, it's most likely they're doing this and not doing any of this, teaching, because I know most behaviorists don't know how to teach stuff properly. They usually do this. Or maybe they do know how to teach, but then they're using just discrete trial and nothing else. So then they're not doing something right, because it has to be everything. It has to be everything. So now I'm going to make you into behaviorists, okay? These are the questions you will ask yourself. Why does my child do those things? Why? Okay, from a behavioral perspective, everything we do is to get something good or avoid something bad. Everything. Think of any behavior. You are here today. You came to this conference. That's your behavior. Why are you here? You probably want to get some good information, and you probably are trying to avoid work or something. Who knows? You're here, most of the time it's actually controlled by both of these things. You're going to get something good and avoid something bad. With our kids, the challenging behaviors they do is the way they are telling you what they want. They're trying to tell you what they want to get and what they want to avoid. Your child may not really pay attention. He may not care that it's inappropriate, because how do we define inappropriate? We define inappropriate as something that is unsafe, embarrassing, not adaptive. Well, guess what? Our kids don't understand any of that. Our kids don't get embarrassed. And you'll understand why in a minute, because I'll talk about perspective taking. So to them, the way they're expressing to you, and anyway, all typical kids will tantrum, right? When they're younger. It's just that our kids, they grow up and they keep doing that because it's more functional for them. It's easier for them. And our kids may not even have the skills to communicate properly. If you don't have the skills, the language, then you are going to have challenging behaviors. So keep in mind, what we're doing right now is we're just talking about the challenging behaviors. Then after this section, we're going to go and talk about skills and how we teach skills. But we have to, when a child has a lot of challenging behaviors, it's really hard to teach them anything. because they're tantruming, running away, hitting you, throwing items, etc., etc. So you kind of focus first on dealing with the challenging behaviors, and you take it easy on skill teaching. Like you teach very easy skills, very basic stuff. Why? Because you just want to reward. You want to reward the child for something good, the teaching of the skills, and not reward for bad behavior. I'm going to give you some examples. But first, take a look at this. What are some things our kids may want, and what are some things they may avoid? Okay, well, they might want attention. Doesn't really matter if it's good or bad. They want attention. They want objects, like foods, maybe, fun activities, toys, the playground, right? They want various things. It'll differ. And this is, by the way, these are your reinforcers. Very important thing to identify with your child. Please make sure you know the things your child likes. All of the power of behavioral intervention has to do with reinforcers. And I'm going to give you a funny example. Some of you who've seen my talk before will have seen this. This is from America's Funniest Home Videos. Tom Bergeron, actually, who's the host of this, is a very good friend of ours, and he raises a lot of money for autism. He does all of I have another foundation called Autism Care and Treatment, Act Today, and he has been our spokesperson, and he raises a lot of funds for us. But this is from his show. You guys have America's Funniest Home Videos, right? And it just shows what happens when a child is seeking attention. And more importantly, this video gives me a time to have a drink.
Number 7, the crying game.
I'm going to stop. Do you know how many times that happens? Like 4 times it goes back and forth. This child's doing that. It's cute. And it's genuine, right? I mean, he looks upset, right? But he stops as soon as the person watching goes to another area. And what does that tell us? Just looking at the behavior and just looking at what he does when the person moves away tells me he's doing it for attention. That's what he wants. Because you can't get attention when a person is not there. Who are you going to get attention from? Right? So it identifies the function, the way he's behaving, tells you that he's doing it to seek attention. He's not doing it because he's in pain. If he was in pain, he'd continue doing it. Didn't matter what room you're in. Okay? But that's important because what was I saying before? I will treat attention-seeking behavior different than pain behavior. Okay. Let's go back to, we were talking about some things kids want and some things kids want to avoid. Having to work, being in a classroom, listening to people telling us what to do all the time, giving up something they want to keep, that's important. Taking a bath, it's different for each child, okay? So the previous list was their reinforcers. These are the aversive things. These are their punishers, right? And you need to know these. Because if you remove these, like if you don't make someone work, what is that called? Vacation. Vacation is what? A reinforcer. So removal of any of these bad things is also a reinforcer. That's important. Yeah, getting ready in the morning. Like this morning, Lori called me very early in the morning and said, I heard your flight got canceled because of the fog. I was like, no, I'm just sleeping. I'm here. I'll be there. So most of the time, our behavior is controlled by both things. Of wanting to give up something, having to give up something that we really want and something we really don't want. Like stop playing, which is a good thing and we have to stop it, and come inside to eat dinner, which I don't want to eat dinner because it always causes me pain. right? From the child's perspective. Wake up, I don't want to wake up, and go to school. Good Lord. Right? Not just wake up, but go to school. So there's all this stuff that it's always a positive that you don't want to give up and a negative that you have to go into. So it's hard. So why do we do all these things? Tell me, why does a typical child do this? You know why? Two things, two controlling factors. Your approval is more important to them, so they do it. And they like to have friends, peers. Some of our kids are they just get up and do it because mom says I have to do it, and I want her to approve of me, or I'd rather avoid her wrath. That'll be my son. So, I have friends. I want to go to school. And guess what? Kids on the spectrum don't care about either one of those. They just don't. They're not aware enough of your reinforcer of, they're proud of me. That means nothing to them. And they don't make friends very easily. So it's more like torture. So essentially, you're just giving them two bad things. Get up and go to school, and I know you hate it, but you have to go. So everything has to have some background reinforcer. So here's some examples. Jenny's playing with her favorite toy, and the parent says, put your toy away. Jenny starts protesting and crying, and guess what? By protesting and crying, what is she trying to communicate? She's trying to say, I don't want to put my toy away. Can I play a little longer? And isn't that what our typical kids do anyway? They negotiate. I mean, how many people here have kids where you tell them, stop, go inside and take a bath right now, and they do it instantly? I'm a behaviorist, and all my kids have learned to negotiate. Or how about, Jacob hates taking baths, it's time to take a bath, so he throws himself down, and he does accomplish something. Most of the time, he'll avoid the bath for a little bit longer, right? And I am a parent, and I'm tired, and oh God, do I really have to give him a bath tonight? Forget it, maybe I'll just give it up. Maybe I'll just skip it tonight. It's no big deal. He had a bath last night. So it was effective. What he did was effective. He got to avoid. It was effective. Remember, we want to do things that are effective, that help us avoid bad things. So remember again, what we're trying to do is we want to get something good and avoid something bad. Challenging behavior is your child's way of telling you what he's trying to get and what he's trying to avoid. Can we figure out what the child's trying to say? Here's some examples. And when behaviorists say, I'm trying to figure out the function of the behavior, it's basically I'm trying to figure out what my child is trying to communicate through this behavior. We study behavior by looking at the behavior, the antecedent, and the consequence. This is called a three-part contingency, the behavioral contingency. It's a very important term in behavior analysis. It helps us understand why a behavior happened, and it's the only way we change behavior. Now look at this. Todd wants a toy. Todd hits his sibling. What usually happens when our child hits their sibling? Most of the time, they get the toy, right? They'll hit and grab the toy. That's typically what happens. What if he doesn't get the toy? Then it didn't work, right? Hitting didn't get me what I wanted. So I changed the consequence. I make sure that he doesn't get the toy when he hits. And guess what's going to happen? The child's not just going to keep hitting. If the reason he was hitting was that he wanted to get the toy, and you don't let him get the toy, he won't keep hitting. He doesn't just get a thrill out of hitting. He's only hitting because he's trying to grab something. What if you teach him to say toy, and whenever he says toy, you give him a toy? Guess what? That's more effective. He's going to use his language rather than his behavior. It's really theoretically that simple. It's very, very simple. John hates school. John screams every time he's in class. What happens when a child screams in class? Oh, they're sent home. How effective is that? I don't know why all kids don't do this. They haven't figured it out yet. So realistically, now what happens? And as he gets sent home, he realizes every day, oh, this was awesome. I'm going to keep doing this, right? So that behavior increases. See how you manipulate the behavior because you did change the consequence. What if he's not sent home? If he's not sent home, he will eventually stop screaming. Eventually, okay? And what if he likes school? What if you teach him enough skills so when he goes to school, he actually is making friends and he loves it? He's not going to scream. And then his not screaming will be rewarded, okay? Mark wants attention. Mark cries and tantrums. And what happens when our kids cry and tantrum and we don't really know what's wrong with them and they're young and cute? We go up and pick them up, right? So he gets attention. That's a very typical thing that happens. So this becomes functional. It increases, it's useful. And in all infants, this is useful. What a mom said to me one time was, you know, it's interesting because it's really a continuum and it's very true. This is very normal that our babies will cry and we'll go pick up our babies, right? But with kids on the spectrum, it doesn't change. The reason it changes with typically developing kids is because then they learn language. So they don't have to, then the effort of crying and you trying to figure out what they're trying to say is harder than just saying, juice. You know what I mean? So they learn juice, and they point to juice, and you give them juice. If they didn't have that, they'd have to freak out for half an hour, and you'd have to figure it out. But for kids on the spectrum, they don't develop that ability to tell you what they want. So they keep doing this. So they get older, and they're still doing this. Now, if he doesn't get attention, again, this behavior goes down. If you teach him something appropriate to do, like, say, juice, and then he does that appropriate thing, then he gets attention, then the appropriate behavior increases. You notice how we're manipulating the antecedents and consequences? All I'm changing is these things, here and here, the two sides. Okay, so summary. You identify the behavior you want to change. You identify why it's happening. What's the function? What is he trying to tell you? What does he want to have, and what does he want to avoid? Now that you know the function, you can change the behavior. How? Change the antecedent or the consequence or both. The function tells you what to do. Make sure he gets what he wants for doing a good behavior, and make sure he does not get what he wants for doing a bad behavior. That's a summary of what ABA is, very simply put. You can always give something good after a behavior occurs, and that's called reinforcement, and it will increase the behavior. You can always remove something good after a behavior happens, and that's called response cost or extinction, and it will decrease the behavior. You can always give something bad after a behavior occurs, and it's called punishment. And punishment decreases the behavior. Or you can remove something bad, and that's called negative reinforcement. And remember, that increases the behavior. It's like removing the alarm clock, right? Those are things. Now I'm going to show you a couple of quick videos. This is a little guy, P.D., and the therapist, he's tantruming because he wants something and she's ignoring it. That's what's called extinction. So she's ignoring the bad behavior, and in the next video, she's rewarding the good behavior.
I want a chocolate burger!
So he's kind of throwing a little tantrum there because he wants peanut butter, right? And if she was to like prompt him or try to give him the peanut butter and or cracker or whatever it is, then he would learn, oh, it is pretty effective that if I throw a tantrum, every time I do that, I'm probably going to get what I want. So she ignores him. Instead, she waits him out. Why? Because we know separately in the past, we've taught him how to ask for things. And now here, this is called differential reinforcement of an alternate behavior.
I want a cracker!
Now he's asking for a cracker.
A cracker!
But he's still kind of fussing about
A
it.
cracker!
It's not nice asking.
go.
I need a peanut butter.
Of course, it'd be good if she didn't give him a knife. But nevertheless, she's, very happy that he did the right thing there and asked for it nicely, and so she gives him peanut butter, right? So she rewards the appropriate way of asking and doesn't reward the tantruming way of asking. And that's just a sample. But the most important thing is that the child has to have the skill, right? So we can modify those consequences and antecedents, but what if the child has no other way of asking? What if he hasn't learned? So that's why I said in the beginning that you have to do behavior intervention, behavior management at the same time as doing skill teaching. Skill teaching is the most important part of ABA. If the child doesn't have appropriate skills and they're easy to do, then he's not going to do, if he has them, he's not going to do challenging behavior. If he doesn't have easy, appropriate skills, how else is he going to communicate? He's going to keep tantruming, he's going to keep hitting. We can't just ignore or extinguish challenging behaviors without replacing them first with something more appropriate. That's really important. Our program has, and this is why now I'm going to give you samples of things, because there's not enough time. In our program, there's somewhere around 3,000 or so individual skill areas that we teach, and targets are somewhere around 42,000 was the last count. And that's only for children up to about age 6 or so. Okay, 6-year functioning. That's what God did. Don't look at me. God gave us 42,000 skills before the age of 4 or 5. So for us, as behaviorists, we want to teach our child all the different things he didn't learn, right? So here, let me just explain it a little bit better. We have this website called Skills for Autism. It's one of the resources that I'll give you at the end. On Skills, there's a whole section where you answer a bunch of questions and it helps you identify the challenging behaviors and the function of the challenging behaviors. Like my child hits, and then it'll ask you, does he hit when it's this time? Does he hit under those circumstances? Whatever, and it'll help you identify what he's trying to communicate. What is he trying to avoid, or what is he trying to gain? And then it'll tell you how to modify that behavior. Then Skills has a whole different section called the Skills Assessment, and it'll ask you somewhere close to 20,000 questions. It's ridiculous. It's really a long questionnaire. I apologize, but I'm very obsessive-compulsive when it comes to my kids, so I don't want to miss anything. And so you'll get more questions as your child ages. Obviously, if you're like a 2-year-old, you'll only get, maybe 1,000 questions. If you're a 3-year-old, you'll get 2,000 questions. It's a little bit more. And the questions are just yes or no. In all areas of functioning, in all these areas, language, adaptive, motor, academic, play, cognitive, social, and executive functioning. So the questions will be very basic things like, can your child, like that'll be, I guess, in motor, can he imitate? If you do this, will he do the same thing? Language, very basic stuff like, does he imitate sounds like ba, ba, ba? To advanced things in language, like, does he understand, does he communicate with his peers? Does he have conversations with his peers? Social questions, executive. So it's all yes and no questions. You answer all of those. And guess what? It shows you exactly what your child is not doing that they should be doing given their age. Okay? Like I remember when I was the first time I had a child, I was looking at that book, What to Expect When You're Expecting or something. You guys know all that book, right? And the cool part that I liked about that book was it told you what to expect at each age level. And with your kids, what you want to know is, what are they doing that's delayed? What are they doing that they shouldn't do? What is the typical child of exactly this age supposed to be doing? Right? And so Skills tells you that, and it shows you these beautiful charts, and it says, hey, this is the delay in this area, this is the delay, and guess what? It's not just the percentage of delay, but it'll tell you exactly how to teach everything that he's supposed to be doing that he's not. So anything you say no to in any of these areas will then link to a lesson, or 200 lessons. A lot of lessons. So whether you say, oh no, he's not imitating sound, or you say, he doesn't know how to tell a lie. Okay, it's all the way to age 8 normal IQ. So and I'm going to show you some of it, and it'll tell you how to teach that, and it'll tell your teachers how to teach it, and it'll show you a video, and everything. Everything you need is in this software. So for instance, I don't have time to show you all the different areas, but I'm just going to give you an idea that it's a lot of stuff. So for instance, like identifying body parts is a skill that typically develops before the first year. Some body parts, not all. And skills is completely developmentally formatted. So it'll tell you at the appropriate age how to teach any of those things if you say your child can't do those things. Here's an example I'm going to show you quickly of typical language ABA, okay? And we call it mixed operants because what we're teaching here is a variety of things. We're teaching manding, which means requesting things. We're teaching tacting, which means labeling things. And we're teaching echoics, which is like repeating the sound so it's more perfect. And we're teaching intraverbals, and intraverbals mean conversational type skills. So it's a combination of operants in this lesson. This is the typical ABA you may have seen, okay?
Give me first now.
Can you ask nicely?
I want the book. I want the book.
Okay. Look.
It's the fireman.
That's right, a fireman. And look.
It's a ballerina.
Ballerina. You're a smart boy. What a smarty you are.
So here he's
What about
tacting, he's
that one?
labeling.
It's a cook.
Yeah, that's a cook.
It's a musician.
A musician.
It's a pilot.
A pilot, you're right.
What? Who is it? Who is it?
That's a nurse.
So he asked, who is it? He's learned that.
It's a fisherman.
Yeah, can you say that better? Fisherman. Nice.
So, and this goes on for a while. I don't want to take up too much time with this, but he's learned from us, and this is one of my favorite kids of all time, Kyle, because he was just unbelievably cute. But he learned everything individually. When he first came, he was completely nonverbal. Okay, so he learned individually to repeat, and you can see he still needs a lot of work there on his articulation, but he's learned concepts like labeling, and then she'll go on now and ask what each one of those people does, and so he's very connected, right? Do you see the eye contact and how connected this was his therapist for a long time, and it appears that sometimes when I watch this video, I think Marla's poking him too much because he's reacting to it, but oh my God, they loved each other, these two. Like, they were together for 5 years. He loved Marla. And the thing about Kyle is that, like, he's so aware now at this point that he learns everything pretty fast. And I don't, I have videos, thousands of videos of my kids where I can't even get them to sit for 5 seconds. But that's my first goal then, is to come here and sit down. So, and that's in nonverbal imitation, or it's in compliance, and it's one of the skills in just adaptive skills, right? And so we start from 0 skill. And then we go on to really cool stuff. And it just keeps going. And I'm going to keep coming back to this concept. I'm going to show you just a couple of things. Don't have a lot of time, but I'm going to show you some. So this is social skills. Our social skills curriculum area. These are some of the things that we teach, and these are some of the things that are in skills in our online program. And let's see what they are. Non-vocal things like eye contact, regulating facial expressions, social language. It's funny because a lot of people always say to me, parents, why don't you just put him in school and he'll learn how to communicate with other kids? That does not happen. Do you know what communicating with other people involves? This is just social language. Okay, so if I want to have a conversation, these are the things I have to do. I have to greet people appropriately. That means I'll greet you in a different way than I'll greet my kids. Right? And everything is different. Like if I come to you, if I meet you, I'll say, hi, nice to meet you, I'll shake hands. See my kids, I'll hug them. That's a very different type of thing. So you have to learn each of these concepts given the audience as well. I will learn how to introduce myself and ask you appropriate questions. My prosody, the sound of my voice, is important and how it goes. I'll regulate your behavior. I'll try to keep you interested. This is what kids are not paying attention to, our kids. You know, am I keeping the group of other children interested in what I'm talking about? Who is my audience, my conversational audience? Am I talking to another child, my mom, a friend of my mom's, the teacher? All different, how you approach adults. Physical context. Are we on the playground? Are we in the library? Are we in my kitchen? That alters your conversation. Listening. Am I listening to other kids enough? Or am I going off on my own subject about geography? Am I initiating conversation appropriately? Hey guys, can I join in? Versus, do you want to play if it's one person versus an adult? Am I joining appropriately? Am I maintaining and repairing? What if they're walking away from me? Oh my gosh, that means they're getting tired. Like these people. Why are you leaving? No, I'm just kidding. But see, our kids have to be aware of all of that, right? And how can you just go in and join a group of kids if you don't have each of these steps individually? But also ending a conversation. How many of our kids actually just walk away from someone talking to them? So all of that has to do with just one lesson area, social language. Now you realize why there's 33,000 whatever in there to teach. Okay. Social interaction, a whole different area of apologizing, assertiveness, all of that. Self-esteem. This is a very important area. Dealing with conflict. This is so huge for our kids. You know how sad they become when they fail at something, or how, you know, they think, oh my gosh, I can't never keep up with this. It's very important to develop skills for our kids in these areas. Social context. Understand, I'm going to show you a lesson in there. Social rules. What are the rules I have to follow? Group-related skills. You know, our behavior changes completely when we're in a group, right? Like you wouldn't, if you were one person in here, we'd probably be having dialogue. Okay? Absurdities, how to tell jokes, how to lie, all of those types of things. Okay. This is a lesson called responding to social cues. And here, we're trying to get the child to pay attention to the therapist's sound and facial expression rather than her telling him what she likes and doesn't like.
This is dressing. That's good. That's good.
That makes no sense to him because he hates dressing. Okay? But of course, he loves the lollipop.
Can I have some? I'm hungry. Which one do I want? Watch. That's good. It's yucky. I'm hungry. Can I have some food? Good. That's what I want. What do I want? I eat the dressing.
And see, at this point, Logan was pretty nonverbal. Like, he had very little language, but his executive functioning skills had developed to the point where he could actually pay attention and really look at her facial expression and understand the sounds. And that was very important for him. So that was one area that I showed you, just social skills, and I just showed you one example. Cognitive skills. Am I okay? I'm okay. I know I have 5 minutes, but then am I not supposed to answer questions after that? So it's kind of still my time? I'm just gonna, yeah, I'll keep going for a little bit. Thank you. But 5 minutes is good too. So cognition. This is how we define cognition. We talk about metacognition, which is identifying your own, and social cognition, identifying other people's or inferring other people's emotions, thoughts, knowledge, desires, beliefs, and intentions. What are my own emotions, and what are your emotions? What do you think? What are your thoughts? How much do you know about the subject? What's your desire? What are your wishes? What are your intentions? Okay, and how do we do these things? The way we do these things is through inferences. We read each other's mind. We're not even aware of how much we read each other's minds. Lori, is it okay if I go over a little bit? 5, yeah, great. Max 5. But am I not supposed to answer questions after that?
You can, but we'll let them go, and the ones who want to ask questions can come up.
Okay, great. So here was the classic test of theory of mind or perspective taking. It's called the Sally Ann task. Some of you guys may know this already. This was done many years ago in Cambridge in England. This was Simon Baron-Cohen is the person who came up with this concept. He had 3 groups of kids. He had kids with autism, kids with Down syndrome, and typically developing kids. And they were around age 5 and older. And he showed them a cartoon. The cartoon had Sally and Ann, this is Sally and this is Ann, and 2 containers in the room. And Sally takes her ball and she hides it, she puts it in a box, and then she leaves the room. Okay, and then Anne goes over while Sally's gone and takes the object and moves it to a new location. Okay, then Sally comes back, and the kids who are watching this cartoon are asked the question, where will Sally look for her ball? Where does she think her ball is? And how would you answer that? She thinks her ball is in there, right? Because when it was moved, she wasn't there. So she doesn't know. Okay. Interesting, the typically developing kids said the same thing, and the kids with Down syndrome even said, oh, it's probably going to be here, because that's where she thinks it is. But the kids with autism predominantly said it's in the new location. She's going to look in the new location. Why is that? The reason is that they don't have the ability to understand that Sally's mind is separate from their own. So if I, the child sitting there watching this, saw it being moved, then Sally knows that too. Okay? Everybody knows everything. We all have the same mind. So what does this lead to? This leads to a ton of different delays. This is called perspective taking, right? Or theory of mind. The kids with autism don't get it, that minds are separate. They don't share thoughts. So how does this thing develop? We just looked at it. First few months of life, we develop a sense of self. Already by 9 months, we start to develop this thing called joint attention. Joint attention is a baby will look at a mom's eyes and will be like, what are you thinking or looking at? Oh, you're looking at the TV. Oh, okay. And you'll track someone's eyes. Or you don't know what I'm thinking about, but I'm going to show you. That's what I want. I'm showing you. That's why our kids don't develop pointing. They don't develop pointing because they think you should know. You should know what I want. I'm crying. Why don't you get it? Aren't you in my mind? So a lot of things are affected by a lack of theory of mind. A lot of things. We don't understand other people's intentions. We don't understand emotions. We become kind of egocentric. The world kind of rotates around us because you should be the same. Like we're all the same mind. Anyway, we never learn how to lie, because how would you lie if everybody can read your mind? We teach our kids how to lie. It's a very adaptive skill. It is, right? And so we designed these curriculum areas. We teach our kids how to understand other people's emotions, how to understand cause and effect, senses, sensory perspectives. This was the video that I would have loved to show you, but it's a long video. And if you go on our website, you can see it. It's called Blindfold Task. And it's like a 7-minute video. I have to have them cut it down for me a little bit more. But essentially, the way we start to teach our kids how to take someone else's perspective is we'll blindfold the therapist. And the child will stand behind the therapist and start vocally telling the therapist how to get from one area to another blindfolded. So they have to take the therapist's perspective. And this is an awesome video because the kid is saying things like, go forward and then go jump over that. Okay, so they have no idea that her thing is closed. She can't see jump over that or go that way. She doesn't understand that. So these are the ways we start teaching him perspective taking. Another way is we'll have our kids throw a party for mom. And they start out like, having little toy trucks there. And eventually they'll understand what mom wants. So we do a lot of this type of thing intensively so that our kids begin to learn to see other people's perspectives. These are the higher areas of the curriculum. I'm just going to show you now some quick glances at other areas, not video, but I want to show you that these are very important things to teach, and good ABA addresses all of this stuff. You don't just teach rote language. You don't just teach discrete trial, do this and say hello, you know? You're teaching a lot of abstract stuff. Executive functions essentially mean planning. Behavior that involves planning, okay? So behavior that where you have to actually focus on an end result and take steps to get there. And if I can teach my kids to do that, believe me, they're successful in most of the things they do in life. This is what comes into this curriculum, flexibility. How many people here have kids who are completely inflexible and have a lot of trouble with like changing the way they do things, right? So the areas are flexibility and set shifting, being able to go back and forth fast between two cognitive features. I'll show you something about that in a sec. Paying attention to the right things. How many kids sit in class and they are paying attention to the leaves outside rather than the teacher, right? Set shifting is being able to go, like you're watching TV and mom calls you, stop, go to mom, come back to TV. That's sort of set shifting, which has to do with attention. Memory, being able to maintain things that you learn and build on them. Problem solving. Metacognition, planning, self-evaluating, like, oh, did I just spend half an hour, you know, with this particular toy and all the kids are in the other side of the room? Should maybe be looking at them and maybe I should be doing something. We teach those concepts, self-regulation, planning, as I said, and inhibition, which is also very good for ADHD kids. Being able to stop yourself from something that's extremely tempting to go for, right? And these are some of the activities. For instance, this is the children's color trail test. So if I tell you now, go from, what are the colors you see there, purple and yellow, go from 1 purple to 2 yellow to 3 purple to 4 yellow. I can't even find 4 yellow. But that's called, it's color trail test. It's a set shifting exercise. So it helps you to move between number and color at the same time. These are activities for your brain. It just makes your brain function faster and able to shift faster. And our kids have problems with this, big time problems with this. This is another activity called Stroop test. If I tell you to read the first line, you'll read it, red, blue, orange, purple. And I tell you, tell me the colors of the second line. Great, orange, blue, green, red, no problem. But as soon as the 2 dimensions change, I'm gonna tell you, now read it for me, okay? Blue, purple, oh, it starts to get a little bit crazy, right? Or tell me the colors. It's hard, right? Because reading words and color are interacting with each other, so then it becomes hard. These activities help our kids actually, their brains speed up and they start to learn things faster. I am finishing. This is the first year, and I just want to show you an overview. The first year, what we're doing is we're really just doing, when we have really young kids, we're doing a lot of different stuff. We're teaching them how to do some basic language. We're working on their challenging behaviors. And we start to teach receptive identification of really basic stuff. And then we start some play skills, and we go into adaptive skills. Usually it's toilet training. And this is where we start looking at some of the medical stuff and start doing dietary manipulations. The second year, now our child is past the age of 3, and we're up to about 40 hours a week of intervention. I know it sounds a lot, but that's what the dose is. And what we're doing is now starting more on conversational skills, teaching the child how to pay attention to their environment and learn from the environment, emotion recognition, and starting to get a little bit more into the abstract areas. Third year, we are now 20 hours in school because our child is now about 4 to 5 years old. So in school, we start to do a lot of play skills with peers, and we're developing social skills. And now we're heavy into like some of the higher level stuff, understanding and reading other people. And finally, in the last year, usually we do 4 years with our kids, sometimes more and sometimes less. In the last year, we're looking at a lot more emphasis on just handing the child over to society, over to the school, training the people in school, and being able to fade out. Okay, and that's sort of our traditional program, and it applies to probably a lot of the kids, but not, the kids are all very different, so they will go in and out as they want. So, summary. A good ABA program requires good assessment to determine exactly what the child needs, and it requires a lot of hours, okay? If your child's older and only has something like very mild PDD or Asperger's type, then that's fine. Then you're doing what's called focused behavioral intervention. But if you're doing a comprehensive program where your child has deficits in a lot of areas, don't mess around, okay? Doing 5 hours is not going to do anything. There's research, there's 100 articles on the subject that 5 hours will do nothing, okay? So the thing is that 40 hours is the dose. 26 to 40 hours is what constitutes correct ABA to begin with, comprehensive ABA for young children between the ages of birth and let's say 6 or 7. Past that, you're focusing. Okay? So what I want to say is, this is the biggest issue. The biggest issue is, when I travel and I do these talks, people will say, oh, I've been doing ABA for years, it didn't work. Guess what? If you take a medication at 5 milligrams instead of 40 milligrams, that won't work either. It's not going to work. Okay? So it's important to pay attention to that. Here are some resources. I think they're in your packet as well. This is Skills, which has assessment, curriculum, treatment tracking, and a timeline. The timeline is spectacular. Can I just say, this is where we track. It's a graph. It shows your child's learning rate and behaviors, and it shows medications, school changes, everything on the same graph. So it shows when the child changes medication, if they do better or if they do worse. It shows when you do a dietary intervention, if the child learns faster or not. This is my school for teaching, training, and this is all video and live webcast interventions on here. There's modules for teachers, parents, whatever, everything. And this is our show. Autism Live is a program that you can go on, and it's on every morning, West Coast time, from 10 to 12, every day. And Wednesdays at 10 is when I answer questions. I'm on there every Wednesday at 10. And so I won't have a lot of time to answer questions here today. So if you have any questions, or if you need anything, if you want a copy of this talk or whatever else, just email, get on Autism Live, send an email, or actually call in or email during that time, because that's what we do. We just do live answering of questions and topics and stuff during my time, which is called the Dr. Doreen Show or something. And this is my video that I made a few years ago, Recovered, which tracks 4 of my kids from the time they're 3 to the time they're like 16, 17, and you can see them go through everything. By the way, on YouTube, we now have a series called Mission Possible, which I think is now about 10 of my families who show their kids at diagnosis and recovery. And these are small 20-minute segments of 10 different families, and you'll see them talking and what they were told and what their kids went through. And for the real skeptics, I have another show called The A Word, which is, get this child is now 5 years old, and we started videotaping him weekly from the age of 2. So it's every week from the time he was 2 till 5, and he's just moving along in his program, and he's almost recovering. So you'll get to see all of it weekly, if you have time for that. It was a pleasure talking to you. I apologize that I rammed a massive amount of information in here. Thank you very much.